things I couldn't find anything scientific or medical, but I did find out that the first Mardi Gras in New Orleans was held February 27th, 1827. 1827. And there were some cool birthdays, Constantine I, Elizabeth Taylor, and the Russian who stole secrets from the atomic labs in the United States and went back to Russia and constructed the first atom bomb in Russia. On the other hand, after I looked for deaths, I did find some cool stuff. All right, so if any of you guys wants to die, February the 27th is a good day because there were lots of Nobel Prize winners. Okay, George Hitching, who worked considerably with chemotherapy and won a Nobel Prize for that. Conrad Lorenz studied animal behavior, applying that to human behavior. Ivan Pavlov, yes, our friend Pavlov, and David Hubel, who figured out visual nerve transmission. Last but not least, I have two other important announcements about February 27th. Aspirin was patented on this day. And this will change the workplace forever. Alice Hamilton, a physician, was born on this day in 1869 and wrote workmen's compensation laws. All right, so now it is my pleasure to introduce our speaker today, Dr. Nina Vasavada. Dr. Vasavada is an assistant professor in the Division of Nephrology. She's our undergraduate university and medical training in Ohio, moved to Indianapolis where she did her internship residency, and then did two fellowships, one in clinical pharmacology and one in nephrology. She joined our division in 2004, subsequently took a little bit of time off, and then rejoined us, much to our great delight, in 2010, where she has remained. In that relatively brief period of time, she has accomplished a considerable amount. She's also been certified by the American Society of Hypertension and has developed hypertension as one of her major clinical interests. She also serves as our director for medical student and resident education and has worked very closely with Mike Stillman to reinvigorate our curriculum for the internal medicine residents and for the students who are, coming through internal medicine. So today, Dr. Vasavada is going to talk about a subject that I know plagues everybody's clinics, and that is the issue of resistant hypertension. Nina?
I think I'm supposed to wait until I get a green light, but I'll just use this microphone in the meantime. Thank you so much, Eleanor. Updates on resistant hypertension. So the year 2013 and early 2014 have already been very dramatic as far as updates in hypertension. We'll go through some of the clinical trials, some of the new guidelines, some fascinating cases that have come through our clinics, and some new investigational therapies that we will share with you. I have no financial relationships relevant to this presentation, and we will talk about investigative treatments in the context of future developments. So the main objectives for this talk today, we want to go over what is the difference between uncontrolled and resistant hypertension. When should someone consider evaluating for secondary causes of hypertension? And what are current and investigational treatments for resistant hypertension? We will go through two clinical cases, both with hypertension on 5 or 6 medications, both in a similar age group, but with very different pathologies. Both of those patients that you saw, the cases are uncontrolled. However, we want to ask ourselves, which patients should we spend the resources and time investigating for secondary causes? And for those patients, which specific options exist? So let us first touch upon what is controlled hypertension. The true meaning of blood pressure control is the blood pressure at which you do not have target organ damage. That has been a difficult number to ascertain for a general population. JNC7, as you all know, recommended that 140/90 be the cutoff for the general population for the label of hypertension. JNC8 was just released a few months ago and had one of the most controversial guidelines in hypertension ever published. The specific recommendation number 1 addressed the age greater than 60 population. They increased the goal blood pressure to less than 150/90 based on their analysis of certain randomized controlled trials that showed this as a evidence-based outcome. They had very strict criteria for what trials they would look at and actually did not include in their analyses many of the smaller trials which showed a benefit for 140/90. Because of that, as a group, they published the guidelines. However, of those 17 authors for JNC8, 5 of them, so that is 30% of them, do not agree with recommendation 1, to the point where they have listed, they have published their own discussion of why they believe it should actually be 140/90. What I take away from this is that it is very difficult to ascertain which guideline would be the true blood pressure that would be beneficial for our patients. And this will likely be revised because it is inconsistent with other national guidelines, including the European and Canadian guidelines. Many patients are uncontrolled. So if we look at the population in the United States, about 30% of the individuals have hypertension, and about half of them have uncontrolled. So half of the patients with a disease process have uncontrolled blood pressure. What that translates into here in Louisville is that 130,000 patients here in Louisville have uncontrolled hypertension. If you look at the pool of patients who have uncontrolled hypertension, there is a segment, a subpopulation of those who are at much higher risk for cardiovascular disease, much higher risk for secondary causes of hypertension, and may benefit from very specific treatment strategies. And so to identify those subpopulation of patients who are at much higher risk, the concept of resistant hypertension has been developed. Resistant hypertension has a very strict criteria. Blood pressure uncontrolled with 3 optimal dose medications, one of which should be a diuretic. Blood pressure controlled with greater than 4 medicines, one of which should be a diuretic. Before we assign a patient as resistant hypertension, we should assess whether it's possible that they have pseudo-resistant hypertension. And the 2 main causes of pseudo-resistant hypertension are lack of adherence to the medical regimen and white coat hypertension. Lack of adherence to medicines is a huge global problem. And this data was a retrospective analysis of 36,000 patients who were involved in clinical trials for various reasons. Those patients all had study coordinators that were aggressively following their medication dosing and medication compliance. Many of them had electronic monitoring that would monitor, for example, when the package was opened and when they took the tablet. And in spite of that setting, after 1 year of being on medications, only 60% of patients were adherent with the medications. In clinical practice, the estimate is actually closer to 50%. So as you can see, this is a huge problem and a huge opportunity for us to develop more quality improvement as far as medications. White coat hypertension is the other phenomena which you want to consider maybe causing pseudo-resistant hypertension. White coat hypertension is the situation where the patient has an increased office blood pressure, but a normal outpatient home blood pressure. White coat hypertension is not completely benign. Patients with white coat hypertension have a higher incidence of sustained hypertension and need to be followed closely for that and development of the cardiovascular outcomes that come as a result of sustained hypertension. After you've addressed pseudo-resistant hypertension, we can look at causes of resistant hypertension in the patient. Patients with resistant hypertension can be have primary hypertension, which is essential, or they can have secondary due to either a drug or another disease process that is causing an increased blood pressure. The prevalence in epidemiologic studies has been difficult to ascertain, but it's somewhere between 9 and 20%. The 20% would be closer to patients who are referred to a hypertension specialty practice. There are several demographic factors that stand out for patients with resistant hypertension. These are data collected from the Framingham and the Allhat studies. One of the strongest predictors is older age. Black race is a higher risk for having resistant hypertension. This will likely include Hispanic Americans in the future. If you look at population level blood pressure control levels, white Americans have the best control, black Americans have worse control than that, and Hispanic Americans have even worse control. So it is likely that the demographics will change over time. In the Framingham and Allhat studies, female sex was associated with resistant hypertension and excessive dietary salt. There are a whole host of medications that can increase your blood pressure. And before you allocate the time and resources to do a big secondary hypertension workup, you want to closely investigate whether it could be a drug-induced resistant hypertension. NSAIDs can cause increased sodium retention and hypertension through that mechanism. Decongestants such as pseudoephedrine and phenylephrine can increase your blood pressure. Amphetamines, which may be used for recreational drug use, but also dexamphetamine, which is given for ADHD, may increase blood pressure. Finally, herbal supplements are a growing cause of hypertension. Mahuang and ephedra is a stimulant which was taken off of the U.S. market in 2003. However, it can be purchased online and certainly would cause increased blood pressure. Ginseng can cause increased blood pressure. Licorice or licorice root. So this picture up here in the corner is of black licorice. This is different than the red twisty candy that is out there. The actual black licorice can now usually only be purchased in specialty markets. But many patients use licorice or licorice root as an herbal remedy for sore throat, for dyspepsia, and licorice has a very adrenal-specific mechanism which causes hypertension. So something to investigate. There are many disease processes that can be associated with resistant hypertension. Some of the less common are pheochromocytoma, Cushing's disease, hyperparathyroidism, and aortic coarctation. Some of the more common secondary presentations include obstructive sleep apnea, which increases your sympathetic nervous system output and blood pressure that way. Renal parenchymal disease, which by multiple mechanisms, including increased sympathetic stimuli, increased sodium retention, and stimulation of the renin-angiotensin system, can increase your blood pressure. Primary aldosterone and renal artery stenosis are other secondary causes of resistant hypertension. So the question is, who should we screen for secondary causes? Every patient that you're evaluating for resistant hypertension should be screened for secondary causes with a history and physical. So the European guidelines that were published in 2003 for blood pressure have a very nice, extensive discussion of specific history and physical points to cover in your medical interview. You want to discuss with your patient the duration and trend of control. Did they have adolescent hypertension? Did they have well-controlled hypertension for 20 years, and then for the last 6 months it's been horrible? Did your female patients have any pregnancies that included hypertension or proteinuria? You want to ask them about prescription use, herbal medicine use, recreational drug use, and caffeine. And on our drug-induced hypertension, I neglected to say cocaine is a huge problem in our society and certainly a cause of resistant hypertension. You want to investigate for secondary causes and the symptoms and signs. Do they have myalgias, which might suggest hypokalemia? Do they have claudication, which might suggest peripheral vascular disease and renal artery stenosis? Do they have witness apneic episodes or snoring, which might suggest obstructive sleep apnea? Finally, you want to assess for some degree of target organ damage. A fundoscopic exam is very helpful for correlating hypertensive changes in the retina with the severity of hypertension. Cardiovascular exam, especially for peripheral vascular signs of disease. Family history. Do they have a family member who has had early onset hypertension or early onset hemorrhagic stroke? There are some familial causes of primary aldosteronism which present that way. And so let us talk about case one. This was a lovely patient who came to our office towards the end of 2011. And one thing I do want to convey is how these challenging patients are really multi-subspecialty patients that require a lot of communication and work between several different specialties. With this specific patient, we were very fortunate to have information from our endocrine colleagues that helped us sort through the difficult presentation of this patient. So this is a 62-year-old white male. He presented with a blood pressure of 150 to 160 on 5 medications, medically adherent as far as we could tell. Past medical history reveals type 2 diabetes. His exam was pertinent for hypertension, blood pressure 154/69, heart rate was 66. His serum potassium was low. He likely had a metabolic alkalosis. And so based on that initial screening, we ordered tests to evaluate for primary aldosteronism. So we ordered a plasma renin activity level and a plasma aldosterone level. His 9 a.m. plasma renin activity level was suppressed, and his plasma aldo was high. And so let us use that case to discuss primary aldosteronism. Some of the features of primary aldo. In a hypertension specialty clinic, the incidence has been up to 10%. It is not clear in the general population how prevalent this may be. Some clinical features are elevated plasma aldosterone. The aldosterone is not suppressible by sodium loading. Patients may present with or without hypokalemia, and the more recent discussions suggest that actually less than half of patients present with hypokalemia. Some other features, family history of early onset hypertension or stroke, may reveal a type of primary aldo called glucocorticoid remedial aldosteronism, which is a familial inherited genetic defect in aldosterone synthase control by ACTH. So the top two subtypes for primary aldo are adrenal adenomas and bilateral adrenal hyperplasia. Less common causes include unilateral adrenal hyperplasia, adrenal carcinoma, and GRA, glucocorticoid remedial aldosteronism. It is helpful, you are doing your patient a service if you can uncover primary hyperaldosteronism, because at the same level of blood pressure control, patients with hyperaldosteronism have worse cardiovascular outcomes. This study was a retrospective analysis looking at patients with primary hyperaldo, comparing them with essential hypertension. And in this study, the odds ratio was higher for atrial fibrillation, MI, coronary artery disease, and heart failure in patients with primary aldosteronism. The first step, if you suspect that your patient might have primary aldosteronism, is to obtain a plasma aldosterone, a plasma renin activity, and calculate an aldosterone-renin ratio. There are a multitude of factors which can affect the quality and interpretation of your ratio. Many, many drugs can decrease your renin and your aldosterone. Many drugs can increase your renin aldosterone. If your patient is volume depleted and the next morning you check their plasma aldosterone, it will likely be stimulated. Beta blockers can decrease renin release. ACE inhibitors and ARBs can increase that. And then there are a set of about 4 or 5 blood pressure medicines which are thought to not have an effect on plasma renin and plasma aldo. For this reason, the endocrine guidelines do recommend that you wean patients off of medicines that may interact with your aldosterone-renin ratio, substitute medicines such as the prazosin, doxazosin, terazosin, hydralazine, verapamil, and then check an aldosterone-renin ratio. Practically speaking, this is very difficult. Usually the patient is coming to your office with a systolic blood pressure 160, 170. It's difficult to consider taking patients off of all of their blood pressure medications and substituting them. But we try to get the optimal information that we can. And so the first step in the algorithm, as we said, is to measure the aldosterone-renin ratio. If your ratio is high, and the meaning of high varies from lab to lab, but can be considered somewhere between 20 and 40, then the next step is to confirm that the aldosterone is not suppressible. There are 4 main tests that are used to confirm this. There is a IV saline infusion test, an oral saline loading, a fludrocortisone suppression test, and a captopril challenge. One of those tests should be done to confirm, and if your aldosterone after the confirmation test is above somewhere between 7 to 10, then you likely have primary aldosteronism. After you obtain confirmation that the aldosterone is not suppressible, the next step is generally an adrenal CT scan. And the CT scan will hopefully give you information about either an adenoma, hyperplasia, carcinoma. If you are not considering surgery, then you stop there and you treat them with a mineralocorticoid antagonist. If surgery is an option, then the next appropriate step is adrenal vein sampling. The correlation between adrenal vein sampling and adrenal CT scan is pretty poor. It's like 40 to 50%. And so both pieces of information need to be used together to decide what the true pathology might be. If the adrenal vein sampling reveals unilateral secretion, which would either be by an adenoma or a unilateral hyperplasia, then you want to consider laparoscopic adrenalectomy. And so in our patient who presented in late 2011, we saw the elevated aldosterone-renin ratio in his. Because the renin was suppressed and so low, that ratio actually came up to about 113. We did a saline infusion where the aldosterone after the test remained elevated at 12. We did adrenal vein sampling, which showed that the left adrenal had a high aldosterone secretion. We did a CT of the adrenals, which showed a left-sided adenoma. And then in September, the patient underwent laparoscopic left adrenalectomy. The caveat to this is this took a lot of time to decide between in consultation with endocrine, internal medicine, and nephrology to decide whether or not to pursue an adrenalectomy. After the adrenalectomy, the patient continued to be on tirazosin for prostate benefit, and his blood pressure was well controlled with a systolic in the 120s. And the pathology actually came back as unilateral hyperplasia. So then when you see a unilateral hyperplasia, the question always comes to mind, did we actually miss a bilateral hyperplasia? And I think we can be comforted that that was not the case because the following year, the aldosterone was still very low at 1.7, different from his initial diagnostic testing. We saw this patient in January, and in January, after 1.5 to 2 years after his surgery, the blood pressure was 131/45 on atenolol, hydrochlorothiazide, and tirazosin. This is very classic that you find a secondary cause, you treat the secondary cause, and there is not really a cure for hypertension, but in about 30 to 50% of patients, the hypertension is improved, but they still need medications. Let us contrast that patient with resistant hypertension to a different clinical case that came into our practice. This patient is a 65-year-old white male. He has a history of coronary artery disease, carotid stenosis, hyperlipidemia. He has hypertensive urgency on 6 blood pressure medications. His exam revealed no retinal exudates and other stigmata of peripheral vascular disease. His serum creatinine was 1. His potassium was 3.6. And he had a kidney ultrasound which showed differential size between the left and right kidney. He had an MR angiogram which showed a right renal artery stenosis. And so the question is, what are the different pathologies for renal artery stenosis? What to do with these patients who come in with so many different presentations? The broad category of renal artery stenosis includes atherosclerotic disease, fibromuscular dysplasia, and a renal vasculitis. And for the purpose of this discussion and the clinical trials that we will look at, we are going to focus on atherosclerotic renal artery stenosis. Some features of renal artery stenosis: onset of hypertension before age 30 or after age 55, acute kidney injury after renin-angiotensin system blockade. And this has to do with the GFR changes when you block angiotensin II in the presence of an afferent stenosis. Size discrepancy or atrophic kidney. And then the last 3 are what would be considered high-risk presentations: rapidly declining kidney function, resistant or malignant hypertension, recurrent flash pulmonary edema, or unexplained heart failure. The diagnosis of renal artery stenosis has gone through several evolutions. So the trials that were done in the 1990s and early 2000s used the captopril stimulated radioisotope nuclear medicine scans. As the imaging with CT and MRI have improved, MR angiography and CT angiography have become more popular in clinical trial settings to assess. The initial screening test is a Doppler ultrasound, which can measure resistive indices and velocities. The gold standard for looking at renal artery stenosis is invasive contrast angiography. And it is very, very common to see an MR angiogram which shows a 50% stenosis, and then an invasive which shows no stenosis, or vice versa. So one thing to really appreciate is the very differing sensitivities and specificities that the different screening tests do have. We often come into the clinical dilemma of intravenous contrast in a patient with decreased kidney function. One way to mitigate that is to use carbon dioxide angiography as an initial screen for your renal artery stenosis lesion. So if some prior imaging suggests renal artery stenosis, often carbon dioxide angiography can be used to further characterize the lesion. And then if an intervention is planned, contrast is used, but of course the contrast load then can be much lower. There were 3 major randomized clinical trials in the 2000s, which addressed the question, should angioplasty or medical therapy alone be used for renal artery stenosis? The first study listed in 2000 used blood pressure as the primary outcome variable. The second 2, the Astral study and the STAR study, used kidney function, usually by serum creatinine and measured and calculated creatinine clearance, as the primary outcome measure. All three of these randomized controlled trials, which were very well done and relatively large, showed no benefit. However, there are some important caveats. Number one, in all of these trials, if the physician felt that the renal artery lesion should be intervened upon, they went directly to the intervention. They were not included in these trials. Those would probably capture the patients who had high-risk presentations. Secondly, these patients did not include patients who had severe worsening of kidney disease. So in the first study, for example, the creatinine was less than 2.3. And most patients had systolic blood pressures that were 150 to 160. The third dilemma that needs to be reconciled is the actual lesion itself and the significance of that. So for most of these trials, the mean diameter of the stenosis was around 70 to 75%. It is not clear if a lesion is between 60 to 80% stenotic visually on angiogram. Does that mean it's hemodynamically significant? And there is a growing body of literature looking at the lesions, pressure, post-lesion versus pre-lesion, and calculating various gradients and assessing whether or not that actually has a higher correlation with blood pressure and blood pressure control. These studies did not look at any of that. They did look at the simple percentage stenosis as the parameter for the lesion. Just a few weeks ago, the CORAL study was released in New England Journal of Medicine. The CORAL study was designed in part because the other randomized controlled trials had looked at blood pressure or kidney function, but they did not look at composite endpoints of death, mortality, morbidity from cardiovascular events such as CHF, MI, and morbidity from renal events such as progressive CKD and ESRD. And so the CORAL trial was a large trial, almost 1,000 patients. These patients had a mean systolic blood pressure of 150, a mean estimated GFR of 58, and a mean percent renal artery stenosis of 72. This trial had a very, as all of these renal artery stenosis trials, has a very high overall death rate, reflecting the magnitude of vascular disease in these patients. But at the end of this trial concluded that stent plus medical therapy was equivalent to medical therapy alone. This trial was similar to the others in that if the physician thought that angioplasty needed to be done, they were not included in this trial. So many of the high-risk presentations were not included in this trial. And this is really something to appreciate when you're using medical literature to try and guide your clinical decision. The idea that you have to look at the patient selection in the trial that you're referencing and see how applicable that is to your clinical dilemma. There was a paper just published a few weeks ago looking at high-risk presentations. So this is a retrospective case control study which assessed patients who had high-risk presentations of flash pulmonary edema, resistant hypertension, and rapidly declining kidney function. And in this study, there were two interesting findings. Number one, the patients who had flash pulmonary edema who were treated with angioplasty had a lower death rate. Number two, there was I think the study had like 459 patients. And so there was a cohort of 31 patients who had both resistant hypertension and rapidly declining kidney function. And in that very small set of patients, there was also a seemingly benefit to mortality. This is underpowered, but it is hypothesis generating. So something to appreciate. From this study, I would say you have data that if you have a patient with flash pulmonary edema and a high-risk presentation for renal artery stenosis, you could do stenting as opposed to medical therapy alone, and you would have this data to support you. So looking at the trials together, stent is favored if there is a failure to achieve blood pressure control with optimal therapy, there is a rapid or recurrent decline in GFR whenever you're trying to reduce the blood pressure, or if your patient has recurrent heart failure, specifically the clinical setting of flash pulmonary edema. In other settings, you would likely want to favor medical therapy. If you have a stenotic lesion, stable blood pressure, stable kidney function, you would be justified in providing medical therapy alone. In our patients, so this was in 2012 before we had data, we ended up sending this patient for a right renal artery stent. So as you remember, he had the right renal artery stenosis. And at that time, his creatinine was 1.0. His systolic blood pressure was 204. And what we found, we saw this patient in January of 2014. His blood pressure was 131/54 on the same 6 medications. This, again, is very classic. When you intervene for a secondary cause, it's not that you cure the hypertension and are able to remove the medications, but the blood pressure improves, the blood pressure gets closer to goal. And in this particular patient, the kidney function fortunately remained at a great level. There is a whole discussion of literature on multi-drug regimens for resistant hypertension. One of the more interesting additions to the drug regimens that we have is the addition of spironolactone. So spironolactone is a mineralocorticoid antagonist. It is approved for primary aldosteronism, but also for essential hypertension in conjunction with other agents. This is different than eplerenone, which is actually approved for essential hypertension alone. In this one specific randomized control trial called the Aspirant trial, patients were randomized to receive either spironolactone or placebo on top of their current medical regimen. All of these patients had resistant hypertension, and some of them may have had secondary causes, but all of them were given this particular treatment option. And the primary outcome measure in this study was change in ambulatory daytime systolic blood pressure 8 weeks after treatment. And what you find is that in the spironolactone group, there was an improvement in the change of daytime systolic blood pressure from 9.3 to 3.9 in the placebo group. You can appreciate the huge standard deviations in this trial. So that would imply that there were some patients in the spironolactone group whose blood pressure actually went up by 3 after being treated. And so in spite of that, looking at the 2 cohorts, there was a significant difference. In 2013 and 2014 thus far have been biomedical industry-driven year for investigational therapies for resistant hypertension. Let us look at what renal innervation is. So the kidney has afferent renal nerves, which go from the renal pelvis to the brain. They are mediated by baroreceptors, so stretch promotes activity of the afferent nerves. The afferent nerves then negatively inhibit the efferent nerve, which is going from the CNS to the kidney, specifically to your arterioles, tubular segments. And so this relationship is called the reno-renal reflex. You have afferent stimulation and efferent inhibition of that afferent stimulation. In the 1930s, 40s, and early 50s, when there were no good medical options for treating hypertension, different forms of sympathectomy and splenectomy were used to treat hypertension. So there's one trial here published in Circulation in 1951, which looked at 338 patients who received bilateral removal of splanchnic nerves for high diastolic blood pressure with 78 blood pressure matched controls. And they found that in this cohort, about 30% of these patients who underwent this large neurosurgical procedure had a sustained reduction in blood pressure after 1 year. And so this idea that interrupting the sympathetic nervous system influence on the kidney and that might help blood pressure is a very plausible idea, and it has some caveats. It might work because the sympathetic nervous system increases sodium retention through multiple mechanisms, directly through renal blood flow, indirectly through stimulating the renin-angiotensin system, and directly through sympathetic nerves. However, there are multiple mechanisms which affect sodium handling in the kidney. Renal denervation may not work because there is a baroreceptor stimulation of renin-angiotensin system, which would promote sodium retention by the kidney. There are feedback mechanisms in the kidney which regulate renin release. And finally, the kidney itself has its own intrarenal renin-angiotensin system, which has all components of it, which would be active in a innervated or denervated kidney. Animal data has been very promising. So if you look in PubMed, even for 20, 30 years, there have been supportive animal data showing that renal denervation may improve blood pressure. And so this particular study looked at different dietary sodium content given to renal denervated and sham-operated rats, and pretty consistently the renal denervated had lower mean arterial blood pressures. The growing body of animal data had encouraged biomedical industry to develop something that could be used in humans. And so Medtronic, St. Jude, Boston Scientific have all developed their own catheters. Cardiac ablation catheters have been tried as an off-label use of the FDA device to perform renal denervation. And the basic technique, and again, I'm not a proceduralist, so I'm interpreting what I'm reading here, but the basic technique is that there's a femoral artery introduction of the catheter. The catheter is then led through the renal artery, similar to a renal arteriogram. And then the renal artery is given several radiofrequency doses to interrupt sympathetic innervation. Medtronic developed the Simplicity catheter, and Medtronic has been the company that has been in the forefront of safety and efficacy testing for their catheter. So we have data now 3 years out from the Medtronic studies. The first study was an open label, non-randomized proof of concept study. They enrolled patients in Europe, Australia, New Zealand, who had a mean blood pressure of 177 over 100. Their average intake of blood pressure reducing medications was 4.7. And the treatment by renal denervation showed promise. One caveat is that at their 2-year follow-up, they showed that out of an initial 138 patients, they had 18 patients follow. They have data for 18 patients here. But for those patients, they do show an improvement of systolic blood pressure. Now, again, Simplicity 1 had no control group. It was an open label proof of concept study. The 3-year data was published just a few weeks ago. And interestingly, it does show a larger cohort that they followed up. So it's unclear whether these patients were initially lost to follow-up and then recaptured. But the data for them, that cohort shows promising blood pressure improvement after renal denervation. Simplicity 2 was the first randomized prospective control trial. So in this study, they added the specific monitoring of kidney function as an outcome measure. And they noted for that, after 6 months, there was no change in kidney function. The Simplicity 2 trial did show a favorable effect at 6 months. And then the patients who were randomized to medical therapy had the opportunity to cross over and undergo renal denervation. So those patients crossed over and had a favorable effect as well. Simplicity 3 was the second randomized control trial for this Medtronic device. It was planned to be a large trial involving 500 patients. This trial was performed in the United States in comparison with the other trials that were performed in Europe, New Zealand, Australia, and the United States. And was a blinded study in the sense that all patients received a renal arteriogram and was blind to the patient and to the operating staff. A few weeks ago, Medtronic announced that this trial met its safety endpoints and failed to meet its efficacy endpoints. And so the question becomes, why did Simplicity number 1 and number 2 have such good results, promising results, while the randomized controlled trial done here in the United States had negative results? They all had favorable safety profiles. Again, it was the efficacy which the FDA found to be problematic. And there are a couple of concerns that may answer that. Number 1, this was the trial that had a more strict criteria of how to adjust the dosing of the antihypertensive medications. In the first 2 trials, they reflected the use or not use of specific agents. The second difference may be that there may be racial differences in how people respond to denervation. We know that there are racial differences in angiotensin, angiotensin II, in sodium response to the various hormones. And it might very well be that this cohort had Black Americans who responded differently than a predominantly Caucasian European cohort. It may also be that the catheter itself was not the optimal catheter. There are other catheters which are being looked at, and actually several of our Department of Medicine faculty will be involved in a trial looking at the Enlighten catheter, so we look forward to their discussions about results. The differences in these catheters are in delivery, so this has multiple electrodes, so it can deliver more of a dose at one setting, and then the Boston Scientific Vesix catheter is sitting on top of a balloon, and so is promoted as being more similar to what interventionalists are used to using. There is another caveat. If you ablate renal nerves, will they grow back? There is some animal data and some organ transplant data to look at this question. And so in 2013, a rat study was published in AJP, which looked at denervated rats and immunohistochemistry staining for afferent neurotransmitters and efferent neurotransmitters. In both of these studies, what they see is that initially, so this is afferent, so we should be seeing neurotransmitter in the renal pelvis. In the innervated kidney, you see it. In the denervated, you do not. However, after 9 weeks, you do see the increase in the neurotransmitter. Similar effect with the sympathetic efferent neurotransmitter. Finally, we don't have any data about kidney transplants, which are denervated, but we do have data about heart transplants. And in this study published in 2001, after a mean of 4.5 years, about half of the patients enrolled in the study demonstrated some partial re-innervation of their heart transplant. Finally, there may be secondary renal artery stenosis. So there has been a published case of a patient who received the renal denervation procedure, 6 months later had a worsening in their blood pressure, had a renal arteriogram, demonstrated a new renal artery stenosis lesion, which was then stented. So some concluding thoughts. Resistant hypertension is a multidisciplinary, multi-specialty dilemma. Secondary causes of resistant hypertension are opportunities for intervention, and investigational therapies such as renal denervation are currently being evaluated, and their long-term efficacy remains to be seen. Thank you so much for your attention. Just wanted to share with you my life. So I did my residency here at St. Vincent Hospital in Indianapolis. Did my fellowship at IU. This is Wishart Hospital, near and dear to all our hearts because it is changing now to a different facility. Wonderful, similar to our university hospital, wonderful educational facility. This is the Raudebush VA where I had my fellow clinic, my research. You can appreciate the style similarities to our VA. And then these, of course, are my 3 children who have loved the snowy, cold, miserable weather. Thank you.
And I'll quote Dr. Roman again. That was terrific. That was terrific. So I think we have time for a couple questions. If anybody has any questions. Yes.
Well, thank you very much for that review. I think it was really helpful. I want to highlight the results of phase 1.
Yes. Yes. What was that? The Aldo?
That was the primary outcome.
Yes.
Great. So now, the end result of this case was a blood pressure of 131/45.
Mm-hmm.
With the patient on the regimen of atenolol, hydrocortisone, found that that is very now Kenneloff versus placebo, so cardiovascular event are actually better with placebo than Kenneloff. We thought that was good. The question is, was there an adjustment, or this is where was this the end of the story? The second issue is the blood pressure. Again, mounting evidence regarding the phenomenon particularly for us in cardiology, where we're looking at coronary. Was there again consideration of that, and was this
Well, I think that those are very good points. The atenolol probably at some point will need to be changed, looking at that data. And the blood pressure, this particular one is 131, and then other readings have been closer to 140, 150, 140, 145. And so with that, he probably does have room to drop the atenolol, and that would be a likely next. So it would not be the end of the story. And in fact, in him, he does demonstrate that he will need lifelong blood pressure reducing therapy, but probably can let his blood pressure come up a little bit. Yes.
There were some typical parts that you had in 2000, I think, community primary care docs in the area of obstructive apnea that were increasingly set up for secondary cause of hypertension. And yet in my own reading, which is why I'm asking you, I've seen a positive evidence of that treating obstructive apnea actually improves blood pressure, although there are many other reasons for treating that. Can you comment on that? Am I missing something? Or?
There have been several CPAP trials that have shown benefit. And then there have been several that show a neutral effect. So, in general, they are treated for other reasons, but the evidence can be found for both support and not support for blood pressure.
Steve.
The last case in the radio frequency ablation, how do you follow the patient to show that the procedure really did what you thought it was supposed to?
So in animal studies, they would homogenize the kidney and then measure renal norepinephrine content. In the Simplicity number 1 study, they took the first 10 patients. And they did a measurement of renal norepinephrine spillover. I don't know that technique. But they specifically say that they did this measurement in the first 10 to ensure that the way they were delivering the ablation was a complete. We don't know. And that might be another deficiency or another explanation for the variability in outcomes, because we don't know for sure that everybody responds in the same way. It may be that some patients might need a second ablation procedure at some point. So we don't have that human data. Yeah.
Okay. Oh, I'm sorry. One more question here.
Yeah, well, the thing to do would be to measure 24-hour urine sodium. People will say, I add no salt to my food. And then you measure a 24-hour urine sodium, and that will tell you the dietary intake of sodium. It is very common to have a dietary salt intake of 9 to 10 grams for our patients. And that would be a modifiable. And so sometimes what it takes is actually measuring the 24-hour urine sodium, showing that actually you are taking in, 9 grams of salt every day, or during this time period that we took this test. Sometimes I think there's a lack of realization of how much salt is coming in, and so that would be a huge opportunity for improvement.
Okay. Thank you very much, Nina.